你在讲水军吗？专家。
Hello, everyone. Welcome to COXO Free Public Webinar again. This is Jolie. And last course, we welcome the professor from India. I see, many dentists ask many questions. I think many dentists interested in our COXO course. So this time we continue again. This time we invite our professor, very famous professor from Egypt, was Dr. Mostafa. So later we will this time the topic is for the simplifying shaping of the root canal complexity. So this is very difficult. I think dentists meet many cases of the difficult root canal. So after this course, you study well, maybe you can settle many of your headache, you meet the problem. So now before the course, I need to introduce about this webinar, what we need to talking about, and later how to get the lottery and how to get the certificate. So let me see. First, you can see this is our PowerPoint for how to get the certificate. First part, you need to like our COXO page, and in our COXO page, second, you need to comment in this video. Must have comment, then you have the chance to get the lottery. So if you want to get the certificate, you need to do this form. You need to fill your name and your detail in the email like that way in our link. Later I will share the link in the comment. You can see you need to fill this link after 5 days. After 5 hours the course, and then this link cannot use anymore. So within 5 days, I will send the certificate for you. Like this is certificate. This is our COXO certificate. So if any dentist require, please fill the link after the course finish. And then the second is for now. Let me warmly welcome our dealer from Egypt to introduce about now the Egypt situation. Hello, Dr. Sarah.
Hello, Julie. Hello, everyone.
Yeah, I think how about the situation in Egypt now?
Thank God now the situation is better now. And now the business is starting to work well now. And dentists now are, more clinics now are open, and more patients now are going to dental clinics to have their teeth done. So
well, that's good news.
Yes.
Yeah, because some countries, I heard that still many dentists, even they want to stop the clinic. So the COVID-19 really very difficult situation. Many dentists.
Yes, thank God now in Egypt, now we are a little bit stable. Of course, we are following the protocol procedures, but we are opening a little bit. So we are starting to get more and more patients now are coming to clinics.
Yeah, that's good news. So now, because Dr. Sarah is from our Egypt dealer for many years, so let me give few minutes to introduce about our big dealer, MCS company. So Dr. Sarah, please introduce about your company and.
Okay, Mr. Sinai for Dental Supplies, MCS. We are now we were founded in Egypt in 2009, and we have been agents for COXO in Egypt since 2010. So it's a long relationship, and we are now the sole agent for COXO famous handpieces. I will introduce most of the products of COXO product that we have in MCS. We'll start with the endomotors line. Of course, we have most of the endomotors, C Smart 1 and C Smart 1 Pro. They are both wired, and the two wireless models. We have C Smart Mini AP and C Smart Mini. Okay, and also we have the Soko Pro famous night eye files, and we have other kits that are made exclusive for MCS. We have the glide path kit the retreatment files kit, and the S1 Pro kit. Also for the endodontic line, we have two models for the obturation system, the C-Fill and the new C-Fill Mini. And of course, for the handpiece line, we, as I declared, MCS is now the sole agent for COXO handpieces. We have a large variety of
Yeah.
high speed and low speed and straight handpieces.
Mm.
Also, the dental motors, we have the C Puma dental electric motor, and we have the implant motor C Sailor and C Sailor Pro. Also, we have light cures like the new DB686 Nano Light Cure, which have two functions, curing and caries detection functions. And it's very nice, actually. And we have also the Helen and the Dali Light Cures.
About this, tonight the lucky draw the gift is for this
Yes,
DB68
yes,
Nano. Yeah,
yes. Today we'll say
it's a
we will
very
have.
popular model.
Yes, yes, very nice. It's really working well now. Yeah, we are receiving very good feedback from dentists who have purchased the Nano Light Cure. For the bleaching line, we have the Sea Bright bleaching. We have the mobile model and the mounted model. And finally, now in Egypt, today, we have the COXO Sea Clear Dental Microscope. We are really happy to have it now in Egypt. We've been waiting for so long now for
Yeah,
this
really.
microscope.
Wait for the
Yes,
certificate for so long. Yeah.
yes, yes. And finally, it had got the CE, and when we have it in Egypt, and we have a special offer for our fans. Okay, so now in Egypt we have special promotion for the C Clear Dental Microscope. We have a special price now for a limited time. So go join and our online store and
Yeah.
contact us and to know the new offer.
Okay,
Thank
that's good. Yeah. So I think you have all our COXO product.
you. Yes.
Okay, so now it's time for the begin our course. So let me introduce our Dr. Mustafa to share. Dr. Sarah helped me to introduce about more detail from how famous from Egypt, Dr. Mustafa.
Yes, of course. Dr. Mustafa is one of the best lecturers in Egypt. He is assistant lecturer in in British University in Egypt, and he has a certified healthcare and hospital management specialist from the ACE. And of course, we all enjoy his lectures. And today he will be speaking about a very interesting topic, simplifying shaping of root canal complexities. I hope that our dentists will enjoy and will learn a lot from his knowledge.
I remember the first time I go to Egypt to see Mustafa is in the exhibition. Have so many dentists around of him to study to listen the
Yes,
course.
yes, of course.
Yeah, I see very
His
popular in
lectures,
Egypt.
yes, his lectures are really very interesting and full of knowledge. So I think that they will all benefit from his lecture.
Okay, so now let me welcome Dr. Mustafa. Come. Hello.
Hello everyone. Hello Jody. Hello Sarah.
Hello,
Yeah.
Dr. How are you?
Thank you so much for this kind edification, Dr. Sarah. I'm really happy to be here today with you and with COXO company, and of course with Mr. Sinai. And how is the situation in China, Julie?
Yeah, now it's good. Even about 1 month ago, our city in Guangzhou, we have a little case. And then all the people need to go to test. I already tested 3 times.
3 times.
After that, yeah, after that 1 month, no more case. And then now same as before, no normal, not normal now.
Very good, very good, very good to get that.
Okay, so I think now is the time for Dr. Mustafa to share your good presentation. Let me add your screen.
Okay.
Okay, so time for you. Everyone
Okay,
enjoy.
I will share my screen now. So now I guess it's clear and everyone can see it. Hello, everyone. Hello, my dear friends and colleagues and dentists all over the world. I'm really happy to be with you today and to discuss one of the most and hot topics in endodontics, which is the simplifying of the root canal shaping, especially of the root canal complexities. And I believe this is one of the most challenging cases that we face in our daily root canal routine. Also, I would like to thank COXO for giving me the opportunity to share my clinical tips and tricks and knowledge among my colleagues from all over the world. And of course, a special thanks for Ms. Sinai for giving me that opportunity. So if you wanted to talk about the cases that we face in our daily root canal practice, we can see that this is the cases that we face every day, like having a class 2 caries, symptomatic apical periodontitis, having an acute abscess or symptomatic apical periodontitis cases, having a large carious lesion, and the patient is complaining of pain with hot, with cold, and maybe he cannot sleep also. So all this are the root canal cases that we face daily. And this is what we want to see, a decent root canal treatment and simply and efficiently done. And this is our aim in our practice, to see a nice healing, a nice tissue repair, a nice bone formation. Like when we have a large lesion like this one and large bone resorption, and now we can see that after just 4 months of follow-up after root canal treatment, we can see that we have a smaller lesion and very nice healing and tissue repair. So now we are going to talk about the primary endodontic treatments, which are the initial treatments performed in the teeth to prevent or to treat the apical periodontitis. As you can see here in these upper central incisors, I had already a symptomatic apical periodontitis, and there was 2 lesions related to the periapical area of these 2 centrals. And after doing a decent root canal treatment and 4 months of follow-up, you can see that we have a very nice healing. And this is our aim in root canal treatment. But in order to do that efficiently, we should predict our outcome. And to predict the outcome, we can follow the principles which was already present in this Toronto study in Journal of Endodontics 2006 and International Endodontic Journal Systematic Review 2007. And we are going to trace 4 factors: the pre-existing apical periodontitis, either we have intraoperative complications or not, what is the apical extent of the root canal obturation material, and what about the coronal restoration. So for the pre-existing apical periodontitis, we have to know that if we are having no apical periodontitis in the preoperative X-ray, we can see in the preoperative condition, we can anticipate about 93% of healing rate, while we are going to have about 80% of healing rate in case of presence of apical periodontitis. And for the intraoperative complications, while we are doing our root canal treatment, we can see that we have complex anatomy, we can see that we have perforations or separated instruments incidents. So all this will add to the difficulty of the case. And it will add about 20% decrease in the success rate, especially if we are having apical periodontitis, which was discussed before. Also, the apical extent of the root canal filling. And for simply, if we ask ourselves, when should my root canal obturation material end? And actually, it ends at the major apical constriction. So sometimes we are having a long obturation or overextended obturation or overfilling. Sometimes we are having short, and sometimes it's flush. So in the flush, maybe it's going to be the best. If it's going to have the best outcome if you are having especially periapical lesion. Like in this case, we were having a lateral canal which was already filled by the bioceramic cedar, and then we can have a nice healing after 7 months of follow-up. So of course, we are aiming to end our root canal preparation and root canal filling or root canal obturation up to the major apical constriction. But sometimes in the periapical lesion, we tend to being flush with the apex. And of course, not to forget the coronal restoration, because the quality of the endodontic treatment and the coronal restoration are correlated together and are correlated to the presence or absence of periapical lesion. And we all know that the most common cause of the root canal failure is the lack of coronal seal. So when we don't have a good coronal seal after doing a proper root canal treatment and root canal 3D obturation, if we didn't do the good coronal seal, root canal failure will be anticipated and will be very highly predictable. So it's like a root to crown journey. We are doing the root canal treatment and then going to the coronal restoration. And we are considering in this journey many factors like the sufficient remaining dentine, the crown root ratio, the pericervical dentine, the 3D ferrule, and the 3D soffit. But today I'm going to talk to you about the clinical aspect, and I'm going to go clinically. So as the proverb says, let's get our hand messy and start doing our clinical steps, starting from the isolation, moving to access cavity preparation, patency using number 10K file, working length determination, and how to do it either combined or separate step, glide path, shaping, disinfection, and obturation. And please don't forget the coronal restoration. So for the isolation, sometimes we tend to do clampless isolation, as you can see here. And I'm using the flowable composite, as you can see, just to do the secondary isolation and to do also stabilization of the rubber dam. And here I'm using the rubber dam wedging for more stabilization. And as you can see here already, that the fine details matter. In my master cone X-ray, you can see the flowable composite, which indicates already that I was doing isolation during my root canal treatment. And here I was doing a full arch isolation, starting from the lower right second premolar to the lower left second premolar. And this is a liquid dam, which ensures to have more and more isolation, and to ensure that we have secondary isolation using the liquid dam all over. And sometimes I use a flowable composite to do this secondary isolation and also to do some stabilization of the clamp. Here I was doing one clamp-sided already isolation, as you can see here, and this is the liquid dam, and this is the rubber dam wedging on the other side. Here is the clampless isolation and flowable composite, as you can see, for the upper anterior teeth. So moving to the second step, which is the access cavity preparation. Proper access cavity preparation is a must, and we used to have a straight line access cavity, so we don't have any bending of files, because if we don't do any straight line access cavity like this one, we are going to have a contracted endodontic cavity, and during some time the contracted endodontic cavity, you are going to have some bending of files. Also, the access cavity should be as a box shape to act as reservoir for your irrigant material. And please be aware that during this step, the irrigant material will act as lubricant. It will not act as a disinfectant, but it will act mainly as lubricant for the root canal shaping files. But please, during the access cavity, we used to have the traditional access cavity, and we were sacrificing pericervical dentine, and we were sacrificing virgin dentine in the access cavity. But now we are targeting to do more conservative access cavity, or to do the ECEC, the contracted endodontic cavity, in which we aim to preserve the pericervical dentine. So let's ask ourselves, what is the pericervical dentine? It is a 4 millimeter located above and 4 millimeter located below the crystal bone. So we tend to preserve this area in order to increase the fracture strength of the tooth, and especially in the molars. And it's very crucial. So as we can see that we are heading since 2015 towards the biominimalism or the bioconservatism, from traditional endodontic cavity to contracted endodontic cavity, and not sacrificing the oblique ridge. Okay, and here I was just sacrificing some of the mesial side of the tooth because of the MB2 canal, which was located in a mesiopalatal direction, not in a distopalatal direction like always. And here doing contracted endodontic cavity, which is even more smaller than the stopper, and even the small part of the stopper cannot pass through it. But sometimes we are forced to do the traditional access cavity, like in the upper third molars, in the upper 8 or lower 8 wisdom teeth, which are very challenging cases to do root canal treatment to. But sometimes it's a strategic tooth, and sometimes we are forced to keep it. If we can isolate it, why not to keep it? So here I was doing root canal for the upper right third molar wisdom tooth. So in such cases, I will not go for contracted endodontic cavity, and of course I will go for traditional access cavity to ensure that I'm not having any bending of files, especially in such cases where accessibility of that tooth is very, very difficult. And as you can see here, I always tend to take preoperative chrome beam CT, having this COMP-MCT will make my life easier during root canal treatment in such cases. And here I can see the 4 canals: mesiobuccal, MB2, distobuccal, and palatal. Let's see what again. MB1 and MB2, distobuccal, and palatal canal. So having 4 canals where the MB2 is located about 3 millimeters away from the mesiobuccal orifice, the CBCT will be of high benefit and of high importance before doing root canal treatment. So let's discuss about the access designs. According to this study in 2016 by Anal, the contracted endodontic cavity, it didn't have any impact on the instrumentation efficacy or the biomechanical responses compared with the traditional endodontic cavity, especially in the maxillary molars. But please bear in mind that if you are going to do contracted endodontic cavity, you should be doing this using ultrasonics and using dental operating microscope. Because if you did contracted endodontic cavity without dental operating microscope or no ultrasonics, it's better to go for traditional access cavity, and don't go for doing contracted endodontic cavity without using ultrasonics or dental operating microscope, because this may end doing root canal with either missed canals or doing perforations or doing some iatrogenic errors during your root canal treatment procedure. Also, according to this study by Gambrini, we can see that if you are going to do an ultra-conservative or the ninja access cavity, as we call it, this will not add to the fracture strength of the teeth compared with the one done with contracted endodontic cavity. So we have 3 types of access cavities. We have the traditional or the conventional one, we have the contracted endodontic cavity, and we have the ultra-conservative endodontic cavity or the ninja access cavity. So we shouldn't go for the ninja access cavity because it will not add to the fracture strength of the teeth, but it will just add to the complications of the tooth, and maybe it will act as a barrier for doing a successful root canal treatment. And it will add more and more of iatrogenic errors, like adding of more accumulation of the hard tissue debris, the dentine debris, which will be inside the access cavity, and you cannot clean properly due to the ultra-endodontic cavity. So please, just go for traditional access cavity, and if you have the dental operating microscope and you're doing it under magnification using ultrasonics, and you have the right tools in terms of files and irrigation needles, you can go for the contracted endodontic cavity. Bearing in mind that doing root canal treatment with a ninja access cavity or ultra-conservative will not add more, but maybe it will add more to the errors during root canal treatment. So to make it simple and short, the minimally invasive endodontics concept, which we are discussing like for the past decade, it's mainly discussing about contracted endodontic cavity and having shaping of the root canal system to continuously tapered preparation with maximum preservation of the pericervical dentine and irrigation activation. So adding all this together will give you more and more good root canal preparation using the minimally invasive endodontics and good disinfection. This is some of the cases that I was doing using traditional access cavity or contracted endodontic cavity. As you can see here, I was forced to do this sort of access cavity because I had large carious lesion already. As you can see here, already this case was referred to me, and the patient had already a labial veneer. So I didn't want to make any injury to the labial veneer, so I can preserve this recently done labial veneer. And this is ultra conservative access cavity, which I'm not encouraging you to do so unless you have the proper instrument and proper equipment. Here is another access cavity, and another one here. It was large carious lesion. Here I had the MB2 canal, which you can see already the master cone going through the MB2 canal, and you can see here the MB1 canal already. The master cone, you have confluence together, so the master cone, you can see it from the orifice of the mesiobuccal canal. Here I had a large carious lesion and an effective restoration, which was already made, but I used this restoration just as a build-up material until I finish my root canal treatment, and then I will go for the corona restoration, for the post-ancour corona restoration. As you can see here, this is the access cavity, and this is buccal and palatal canals in the upper premolar. Lower molar with 4 canals, another lower molar with 4 canals. And as you can see, we have some extra canals like the MB2 canal in the upper molars or the middle mesial canal in the lower molars. And here in this lower left first molar, I had the mesiobuccal and mesiolingual canals. And this is the isthmus in between. And when we do root canal treatment for lower molars, we have to clean the isthmus using ultrasonics. So why we are removing the isthmus and cleaning it? In order to remove the harbored bacteria in this area. This is the first thing. And the second thing, in order to search for the middle mesial canal. And as you can see, after cleaning the isthmus and removing it here in between the 2 mesial canals, I can see the middle mesial canal, and this is after obturation. So what about seeing a video together in order to can see how we are using the ultrasonics in order to do troughing for the isthmus in between the mesiobuccal and the mesiolingual canal. And as you can see here, after cleaning the isthmus, I can see that there is the middle mesial orifice, and now after shaping of the middle mesial canal, and as you can see, this is the middle mesial canal after shaping and joining with the mesiobuccal canal. Here in such case, I was having a lower first premolar, which had a recently zirconia crown or Emax crown. Actually, I don't remember. It was referred to me by the prosthodontist. The patient was having pain, and this crown, it was having perfect margins, and it was recently made, and no need to repeat it. So I decided to go for the root canal treatment through the crown, and I decided to go for ninja access cavity or ultra conservative access cavity. And as you can see here, in such ultra conservative access cavity, in this orifice, I needed to enlarge the access cavity. So I had 2 options: either to go using my tapered stone, using the high-speed hand piece, and to enlarge the access cavity, and I will end up from being ultra conservative or conservative access cavity to traditional access cavity, or to use the ultrasonics and do access cavity refinement. So I decided to go for access cavity refinement. As you can see here, I tended to go for flaring of the access cavity walls. So when I go for flaring of the walls, this will help me to do more proper shaping and more disinfection of the root canal, and it will help me finally to do the 3D obturation. So this is the access cavity after doing proper access cavity refinement using ultrasonics, and this is the flared walls, as I told you, and no need to increase the size of the access cavity. Here is the access cavity for the lower second molar, having an extra distal lingual root, middle mesial canal in lower molar. So the access cavity, it's a case-dependent scenario. And in order to apply the minimally invasive endodontics concept, you can move from having a traditional access cavity to conventional access cavity to, traditional access cavity to contracted endodontic cavity to ultra-conservative access cavity, which I don't recommend. And this will be a case-dependent scenario. So it's following the anatomy, and you are just doing an anatomically guided concept, where here I had to remove all this because it was already a carious lesion, and here I had to do a traditional, a contracted endodontic cavity, but slightly removing a little bit or doing some refinement on the mesial wall in order to catch the MB2 canal, and here to do the ultra-conservative access cavity. So let's do some recap, and this is the clinical steps we are following, and now we will move to the patency of the canal using scouting of the canal using number 10K file. So when we are doing the scouting of the canal, we have to ensure the patency of the whole canal or the patency of the just or coronal third only or coronal half of the canal. And when we do it, we have to use our number 10K file in a watch winding motion, which is clockwise and anti-clockwise rotations. As you can see here, plus 90 and negative 90, clockwise and anti-clockwise rotations. And don't try to do any apical pressure, just watch winding, and the file can find its way through the canal. And you can see after removing of the file that the file had already taken the impression of the canal, and it gave you an impression like if it's a wide canal, if it's a narrow canal, if it's a curved one, if it's having a double curvature like this one. So we know what we are facing before we start our shaping. Sometimes we go for root canal pre-banding of the number 10K file before we start, and this is the difference between pre-curving and pre-banding. So we go for pre-curving of the file like this one, but the pre-banding we use it only in cases of ledge bypass or broken files bypass. So let's go for the root canal shaping steps, and starting with the coronal flaring. But let's bear in mind that when we are going to do the coronal flaring, we don't want to violate the pericervical dentine. We want to preserve the pericervical dentine. And as we mentioned before, it's the 4 millimeter of above and 4 millimeter below the crestal bone. So when we do coronal flaring, we are talking about the 4 millimeter or the first 4 millimeter of the root, which are the pericervical dentine in such area. So when we do coronal flaring, we shouldn't go more than 3 to 5 millimeter inside the root canal from the orifice. And I'm using the coronal flaring file from the COXO rotary system, which having a tip size of 17 and taper of 8%. And this file, when I go only for the first 3 or 4 millimeter maximum inside the root canal in order to do maximum preservation of the root canal dentine. So we are going to do enlarging of the canal orifice and to achieve the coronal flaring, which will help us to gain more straight line access to the rest of the canal. So when we have a root canal like this one having a curvature starting from the middle third, we will go only for root canal flaring or root canal or coronal flaring only in the first 3 millimeter, like in this case. And so all the files or all the rotary files going through the middle third or the apical third will go with such ease, and it will be more and more efficient during the shaping and having little stresses and less iatrogenic errors or less incidents of file separation. So let's see together. So here is the coronal flaring. As you can see, only in the first 3 or 4 millimeter of the canal. And here you can see a clinical case where I was using the COXO coronal flaring file in the buccal and palatal canals. Here in the buccal canal. And you can see that I was doing already a conservative access cavity. I didn't sacrifice the buccal cusp tip of the root canal. And now that's easily done. After that, after coronal flaring, we go for the working length determination. And actually, we have two schools in such step. Some clinicians prefer to go for the working length determination using a combined step or dual function endomotor, which has already a built-in apex locator like the COXO C-Smart Mini AP endomotor, as you can see already. So I'm having a built-in apex locator, and I will go directly during the glide path step up to the working length, and the file, when it reaches the working length, it will go just auto reverse and go coronally. Or I can use a separate apex locator where I can take the working length in a separate step, and then I will go for the glide path step afterwards. So sometimes I go for the combined step using the C-Smart Mini AP endomotor because of its dual function having the built-in apex locator. And especially I use this in the retreatment cases while using the retreatment files in order to remove the cataperca. And I don't want the files to be just going beyond the apical foramen, because I don't know the working length yet, even if I have an estimated working length from the preoperative X-ray. But I don't know the accurate working length. And one of the most advantages of having this endomotor that it has a very small head, the mini head, giving you more accessibility and more visibility. And the lightweight of the endomotor giving you more and better ergonomics. And of course, as I told you, having the built-in apex locator, so it can speed up your root canal treatment procedure, making it faster and more efficient. And of course, not to mention the rotation and reciprocation modes according to your preference, if you are a reciprocation fan or a rotation fan. Here, I was just using the file in the dual function mode. So when it reaches the working length, just do the auto reverse and it's going up. As you can see, when it reaches the working length, it went up. And this is after shaping. This is the buccal and palatal canal, and you can see how constricted is the access cavity. So after finishing the working length determination, we can go for the glide path step. And in order to have a happy root canal treatment like this little girl, okay, we should do a perfect glide path before starting our shaping procedure. And for the glide path definition, we can see that in the literature we have so many definitions, either creating a smooth radicular tunnel starting from the canal orifice up to the physiologic terminus of the root canal, which can be achieved when the file is entering the root canal from the orifice and following the smooth canal walls uninterrupted until the terminus. And when we say uninterrupted, it means that we are having smooth walls, and these smooth walls are not having any interruptions, which can make your root canal treatment after that more difficult. So we are confirming that we are having a pathway for the rotary shaping files to follow passively the shape of the root canal and to move passively inside the root canal. And when we say passively here, we mean that we are not having stresses on the file. So in order to achieve the glide path, we can use either manual files or we can use mechanical glide path using rotary files. And we used to do it using number 10 and 15 and 2025 K files. But now we are using the mechanical glide path after finishing only with number 10 K file. But let's ask ourselves, what are the advantages of the stainless steel K files for achieving the glide path? Having a good tactile sensation, low incidence of file separation, and of course, giving us an impression about the root canal, like the video we have seen before. And also the stiffness of this hand file, sometimes it helps in negotiating of the blockage or calcification using the C+ files. As you can see here, I had this panoramic view. You can see the lower right third molar, it was a strategic tooth. We need to keep it. And you can see here the severely curved mesiobuccal or the mesial root for the mesiobuccal and mesiolingual canals. And here is my glide path. And you can see my number 10K file following and moving passively up to the working length. And here is my master cone. Here is the distal shaft of the master cone. And here is my post-operative X-ray. But sometimes we shift to the rotary nickel titanium instruments or the mechanical glide path because it's faster and it can help you to maintain the original canal anatomy better and better. You are not going to do some ledges. You can decrease the transportations, and now you are going to decrease the errors and mainly the iatrogenic errors during the glide path step. And also we are going to have the less incidence of the post-operative pain. Here, I'm going to talk about the perfect glide path file from the SucoPro nickel titanium system, because I believe this glide path file having a tip size of 19 and taper 2%. It's one of the most efficient glide path rotary files ever made because of the flexibility, having a moderate tip size, which is 19. So after having a manual glide path and taking the working length using number 10K file up to the working length, I can shift directly up to this file because it has small tip size of 19 and taper of 2%. And of course, added that it's a mechanical file, it's a rotary one, not manual glide path. So I will have less incidence of the post-operative pain and less incidence of iatrogenic errors like ledges or transportations. And of course, I will respect the canal anatomy. And as you can see here, I'm having an S-shaped canal. So let's see together how this file will operate in such cases. You have seen already that the file can follow already and respect the root canal anatomy and without modification the root canal anatomy at all, without doing any threatening to the root canal. So that's why I love this file. After we finish the glide path, we have to move to the next step, which is the root canal shaping. And we have so many objectives for the root canal shaping, starting by removing all the pulp and necrotic tissue, eliminating the pre-dentine and infected dentine inside the root canal, and decreasing the number of bacteria significantly. And of course, one of the most important objectives is to respect the canal anatomy. And after that, we are doing the shaping for disinfection of the root canal to do proper irrigation. And after that, doing 3D obturation. So when we talk about the minimally invasive root canal preparation, we have to be aware of two things. When we do the minimally invasive root canal preparation, we don't mean that we are going to make the root canal preparation as very small. And at the same time, we don't mean that we are not going to do a large root canal preparation in order to increase the cleanliness of the canal. So it's just a compromise between both. And as I told you before, it's a mix between all stuff, the contracted endodontic cavity, shaping while preserving of the root canal dentine, especially the pericervical dentine, and respecting canal and root canal anatomy, and at the same time doing proper disinfection. So in this study, in 2019, they found that the root canal cleanliness, if you did a preparation of 40 tip size and taper of 4%, and you did disinfection using the syringe and needle irrigation, it will have the same effect of cleanliness if you did a master apical file of tip size 20 and taper 4%, but you did your disinfection using the passive ultrasonic irrigation. So here, this means that the disinfection protocol or the disinfection technique or the activation of irrigation will help you for the root canal cleanliness, and that the size of preparation is not only the factor that will decide the disinfection of the root canal. So if we did our preparation up to 20 taper 4 and using any type of activation like passive ultrasonic irrigation or sonic activation, this will help you to do good cleaning and good disinfection of the root canal. And in this study in 2015, we found that the master apical file of 25 taper 4%, it had no significant difference if you compared it to a larger files in terms of root canal cleanliness and disinfection and reducing the intercanal bacteria. So this means that if you ended your apical preparation up to 25 taper 6 or 25 taper 4, and you did your disinfection using sodium hypochlorite activation using passive ultrasonic irrigation or sonic activation, this will help you for more cleanliness and no need to increase your preparation more than that. So for the shaping, we have 4 files in the SucoPro rotary system. And these four sizes are case dependent, which means that I'm not going to use the 4 files in each case of the root canal. I am choosing like 2 or 3 files maximum in each case. I'm not using all the files in all the cases. And in most of the cases, I'm ending my preparation on 25 taper 6%, and I'm using the 2004 and directly the 25 taper 6. Sometimes in larger canals, I will go for the 3504. And sometimes if I have smaller canals or double curvature canals or complex anatomy, I will move to 2004 and then 2504, and I will end my preparation on the master apical file of 25 taper 4 only. So having the file of tip size 20 and taper 4%, I call this file the Joker file, as you can see here. Because this file, I can use it for glide path, I can use it for shaping. So it's kind of mix of Joker file, which can help you to do the shaping step or the glide path step. Sometimes I'm shifting directly to the 2004 for the glide path file, and I'm not using the 1902 in moderate canals. So this file will act as the glide path. But sometimes in complex anatomy, I'm going to use it after the 1902 glide path file. So it's acting as a shaping file. So it's a kind of mix of between. That's why I'm telling it as a Joker file. As you can see here, I'm using it. In the buccal and palatal canals up to the working length. And here you can see the file in the palatal canal. And you can see the coronal debris coming out. The coronal motion or movement of the debris. So the file is not pushing the debris apically. After that, we can go for the shaping of narrow canals and double curvatures with size of 25 taper 4, and we're going to use it up to the working length. And as you can see here in this upper first premolar, it's a molarized molar having 3 roots. In the buccal canal, in both buccal canals, in the mesiobuccal and in these 2 buccal canals, I am having a double curvature. As you can see, I ended my root canal preparation up to 25 taper 4. But in the palatal canal, I can end my preparation up to 25 taper 6. Here in such case, I was using the 25 taper 6 up to the working length in S-shaped curvature, also in this tubercle canal and in the mesiobuccal canal of upper molar. And I'm finishing my preparation up to 25 taper 6% using the Sucupru rotary system in most of the cases. Here in the buccal and palatal canals, I'm using the 2506. The patient here had a very limited mouth opening. And of course, because of the mini head, as you can see, mini head of the endomotor, I can have good accessibility and good visibility. So this is upper right and left first premolar. It was done using the Sucupru rotary system. The fourth file in the shaping sequence is the 35 taper 4%. It's a very good file, especially in cases of long canals. Like for the long upper canine, as you can see here, I was having a very long upper canine, and I can proceed to the working length. And we use it in long canals in order to avoid the full stuck back during the master cone fit. And as you can see, it went up to the working length, and it's very nicely done. So this is the full sequence, as you can see. And I'm going to show you now 2 videos where I'm not going to use the full sequence in each case, because this is not the scenario in my root canal daily practice. The scenario will be as follows. Please, let's watch together my preferred sequence. Patency using number 10K file. This is the coronal flaring. Only 3, 4, or maximum 5 millimeter inside the root canal. And now the glide path for, and as I told you, I'm using the 2004 as a glide path file in moderate cases. As you can see here, I'm using it on 2 times, working length minus 3 millimeter, irrigation, and then up to the full working length. So here in such case, I didn't use the 1902 glide path file. So I'm decreasing the sequence and minimizing the sequence up to 3 files only for the canal. Coronal flaring, glide path, 2004 up to the working length, as you can see, and then going out. Now I will shift directly for the 25 taper 6. And as you can see, the file is going to the full working length. And now I finished my preparation. Also, don't forget to do irrigation between each file. Now I'm having a clean canal, and this is the master confit. And it's easily done. So here I just minimize the sequence into 3 files only. And as I told you, the 2004, I consider it as a joker file. Sometimes I use it for the glide path and at the same time of shaping, and then to increase my root canal shaping up to 25 taper 6. And this is in most of the canals. But when we have an S-shaped canals like this one, we are going to modify the sequence. Patency using number 10K file, irrigation to act as lubricant, coronal flaring. And when we do coronal flaring, please be sure that you are not going much more than 3 or 4 millimeter in order not to go for the first curvature in order to avoid edges. Now, as you can see, going with the 2004 up to the working length. So doing coronal flaring, and then glide past 1902, and then shaping using 2004, and now 2504 on the working length. Irrigation, master confit up to the working length. So this is how I showed you how I can modify the sequence of the Sucupro rotary system in order to use it not in a full sequence, but you can use 3 files like the coronal flaring 2004 and the 2506 in most of the cases. But in severely curved canals, you can go for the coronal flaring 1902, 2004, and 2504. And if you have larger canal, you can end your preparation after 2506 up to 3504, and especially in the long canals, to avoid the full stuck back, you can use the 3504. Here is another case. And I was doing ultrasonic troughing in order to search for the MB2 canal, as you can see here. Also, we have to be aware that in this dangerous area, we never use any handpiece. We only use ultrasonics in order to search for the MB2 canal. Here I'm going to do shaping for the mesobuccal, distobuccal, and palatal canals using the 2506 COXO rotary system. Shaping of the palatal canal. This is another case we are going to use also the COXO rotary system. As you can see here, I'm having a slightly calcified canal or a nearly obliterated canal in the upper molar, in the mesobuccal root, and in the distobuccal root. So that was the situation after doing the access cavity. Here in that case, the patient had a very limited mouth opening, so I can get use of the mini head of the COXO C-Smart Mini AP endomotor. And this is the situation after doing the coronal flaring, as you can see. And I'm going to use the 1902 file directly to the MB2 canal. And after doing some mechanical glide path for the MB2 canal, I went directly for the coronal flaring. So here I shifted my sequence in the MB2 canal in order to follow the pathway of the tortuous curvature of the MB2 canal in the coronal third. So I didn't want to go directly with the coronal flaring, and I went with the glide path directly for the mechanical glide path. Now I will go for the shaping using the 2004 for all the canals, for the mesobuccal, distobuccal, and palatal canals. And this is the outward or upward debris removal, where all the debris are moving coronally and not pushed periapically in order to decrease the post-operative pain. Here I'm using the 2506 in the mesobuccal and distobuccal and palatal canals. As you can see, the debris are located coronally, And actually, I want to tell you one thing. Don't do this, because at this time I should have done some irrigation. Now I will go for the MB2 canal. Using the 2504. And as you can see already in such case, this is a mesiobuccal, MB2, distobuccal, and palatal, beautifully shaped. And as you can see here, the curvatures, I'm having a double curvature and S-shaped curvature in the distobuccal root. So that's why you can see that I'm moving my hand according to the long axis of the root in order to do shaping and to avoid any heterogenic error during my shaping procedure. I'm having a severe curvature in the mesiobuccal root and a very long palatal root. So we are not increasing the apical preparation size in order to not to sacrifice dentine, not to add more stresses after root canal treatment, and to decrease the heterogenic errors during the shaping. And as we said before, that we are doing the shaping step in order to so we can do proper disinfection and proper irrigation. And we actually, it's not our topic for today, but I will just add some clinical tips related to the disinfection, which we are about the technique which I'm using in my daily practice. I'm doing intracanal heating for the sodium hypochlorite using the C-fill pin, as you can see here. When you have the sodium hypochlorite inside the cavity, access cavity, and you go for the intracanal heating for about 6 to 8 seconds, and when you start seeing the bubbling action, you stop your intracanal heating. This adds more dissolving action for the sodium hypochlorite and more antibacterial effect. And after that, I go for the ultrasonic activation of irrigation, which helps me to do two effects. The cavitation effect, which is the formation of many tiny bubbles, and these tiny bubbles do some implosion and having lots of pressure inside, and this pressure will be moved to explosion after that, like a shock wave, in order to remove the biofilm, in order to remove the bacteria inside the dentinal tubule, to remove the bacteria inside the lateral and accessory canal, and in all the root canal spaces. And another effect is the acoustic streaming, and which is going to produce many shear forces, and these shear forces will help to remove all the debris from the instrumented canals upwards and outside of the canal. As you can see here, this is the passive ultrasonic activation or passive ultrasonic irrigation. And this is the activation of irrigation. And after activation of irrigation and after obturation, you are going to see that some of the lateral canals and some of the loops like this one present between the mesiobuccal and the mesiolingual canal are beautifully filled. There is another lateral canal. Here is another lateral canal which was found in the retreatment case in the mesial root of the lower molar, and I was having large radiolucency, as you can see here. And this is after 7 months of follow-up. As you can see, I have a good tissue repair and nice tissue repair and nice bone formation. Obturation, and for the obturation techniques, we have two techniques, and I'm going to discuss them in brief. We have the continuous wave of compaction technique and the synchronized hydraulic condensation. And when we talk about the continuous wave of compaction technique, we have to mention the C-fill obturation device from COXO, having the pen and the gun. So it's a very good device. And let's talk about the C-fill back pen, down pack pen, which can use for the down packing of the master cone guttiperca during continuous wave of compaction technique, softening the guttiperca during retreatment, heating of the sodium hypochlorite inside the root canal, and for the post space creation. While the backfill gun, the C-fill backfill gun, it's very light and it has having an ergonomic design for maximum comfort, and we can use it for the two techniques, either the squirt technique, system S technique, or the continuous wave of compaction technique, and for the 3D filling of the root canal system. So let's see this small video for the continuous wave of compaction technique. Here is the conform master fit cone Gataperca. And this is the C-fill pen up to working length minus 4 millimeter. I'm ensuring that the tip size can reach working length minus 4. The sealer is only at the last 2 millimeter of Gataperca. I'm putting resin sealer. I will go for the down packing up to the working length minus 4 millimeter. I will just hold for 5 seconds without any heat, and then I will go outside of the canal. And now I will use my plugger in order to compact the Gataperca. If I have some softened Gataperca on the walls, I can just push it apically and start doing my compaction. Now the rest of the canal, I'm going to do the backfill using the C-fill back gun. And I will just add my thermoplast size Gataperca or softened Gataperca up to the orifice level. And this depends on the size of the canal. If it's a very long canal, we can do it up to 2 times, or we can do it on 1 time in short canals. And here's a large plugger to compact the Gataperca on the orifice level. And this is how beautifully the 3D obturation can give you a post-operative X-ray. You can see here, following all the irregularities of the root canal. The other technique is synchronized hydraulic condensation, or the hydraulic using the hydraulic cements, which is a bioceramic sealer. And here I'm going to show you how I'm doing this technique, where I'm going to use the bioceramic sealer. And as you can see, master confit. This is an intentionally made lateral canal. This is a bioceramic sealer, and you can see the flowability of the sealer. And here I'm going to use the single cone obturation up to the working length, and this is the sealer coming out from the lateral canal due to the flowability of the bioceramic sealer. And now I'm just going to seal off and cut the Gataperca up to the orifice level. Using the down pack pen. So sealing off the Gataperca, and then using the plugger, compact the Gataperca up to the orifice level. And we finish the obturation. So till now, for the people who are going to ask, till now, the golden standard technique for the root canal obturation and to produce a 3D obturation is the continuous wave of compaction technique. This is some of the cases done using both techniques. Here is a lateral canal filled, as you can see here. That was done using the bioceramic sealer, and unfortunately I had some apical extrusion, as you can see here, but it's a biocompatible and bioactive material, so I'm not afraid. Here is a C-shaped canal, as you can see, and it's all the root canal spaces are already filled, as you can see. Another case is a lateral canal, molarized premolar, as you can see here, having 3 roots. Another case. In this case, it was referred to me after the doctor, I guess. I don't know whether it's a 2 portal of exits, as you can see here, or this is a root resorption. It's a perforation by the previous doctor. I'm not sure. But what I did is good activation of irrigation after good shaping, and then by bioceramic sealer could fill the original pathway of the canal, and this is the false pathway which was created by the previous dentist. Here was there was a broken file. As you can see, I managed to remove the broken file, but there was a still small fragment which I already could manage to bypass, and this is after finishing my obturation. And here I did continuous level of compaction, as you can see, and already I had a middle distal canal. This is upper left first premolar, and sometimes when I'm having double curvatures like this, or S-shaped or dancing roots, like I prefer to call, in these dancing roots, I prefer to use the synchronized hydraulic condensation technique, the single tone technique with the bioceramic sealer for obturation, because it's much easy. Another case of S-shaped canals, as you can see, extra root, distal lingual root. And finally, please, when you finish your root canal, please don't forget to add the good coronal seal, the coronal restoration. Either it's just a composite restoration, like here, or post-anchor restoration, in order to ensure that you're having a good coronal seal, in order to ensure the success of your root canal treatment. And this is one of the most adorable cases I have just done, because that the large lesion, as you can see here, related to the upper lateral incisor and canine. And this is just after 4 months of follow-up, you can see good healing. And this is after 1 year of follow-up, you can see beautiful healing, and nearly the lesion is going to heal, and still the healing is going to continue and come. The take-home message for today: you don't need to increase your apical preparation, because in order to increase cleanliness, you have to depend on the disinfection protocol. But because if you increase your apical preparation, what you're going to do is to sacrifice more dentin and to decrease the fracture strength of the root. Your removal for the tooth structure, either in the access cavity or for the root canal preparation, should be as less as practical according to the case, and it's a case-dependent scenario. The dental operating microscope, the ultrasonics, the experience of the operator, and the operator skills are the key factor for the success of any root canal treatment case. My recommendation would be using the 2506 as your master apical file in most of the cases, but 2504 in the severely curved canals or S-shaped canals or the complex anatomy. Your master apical file in the large canals is chosen accordingly according to the initial binding file, which is considered one of the most important steps, so you can determine which master apical file in the large canal you are going to finish your preparation. And please, for all the cases and the videos and the posts you have seen today, you can follow these hashtags on the Facebook and Instagram, hashtag Anwar Endo, hashtag Extreme Endodontics, hashtag Endotactics, and of course, the new hashtag Anwar Endo Tips, which you can see on the lower left bottom of the screen. Hashtag Anwar Endo Tips, all attached together. You can see most of the clinical tips I'm writing and adding to my Facebook profile and Instagram profile. And finally, I can do nothing except thanking COXO for giving me the opportunity to be among my colleagues from all over the world today. This is a very good chance, and of course, in these exceptional times, what we can only do is to gather and share knowledge. And of course, I would like to thank Mr. Sinai for this opportunity also. And I would like to especially thank COXO for giving this public service webinar as a very good gesture for all the dentists all over the world. Thank you so much. And I hope we can meet again physically, not only virtually like the old times.
Yeah, I think so. I hope I can meet you face to face in age soon.
I hope so much. I hope that for so much.
Okay, I feel thank you so much to Dr. Mostafa for so excellent presentation. How about you, Finn, Dr. Sarah?
Julie, I will stop sharing my screen.
Yeah, now I stop it. Dr. Sarah, I cannot hear your voice.
Can you hear me now?
Yes, I can hear your voice now.
Okay. Thank you, Dr. Mostafa, for this great informative lecture. It's really full of knowledge. I hope that all our dentists got benefit from this lecture. Really, really interesting and very informative. A great work, really.
Thank you so much, sir. Thank you, Dr. Sarah. Thank you so much.
Yeah, thank you. So now let me share about Dr. Sarah's serial screen photo now. Okay, I think for so long time, Dr. Mostafa may be a little tired for speak so long time for the presentation.
Not tired. I'm just being a little bit quiet before talking again.
But we need to take some time to answer a question. You see, wow,
I'm
so
ready.
many
I'm ready. I'm
questions
ready.
now. Yeah.
I'm ready. I'm
So,
ready.
okay, so now let me check the question one by one to answer it. So many questions I see this time.
Let's go.
Okay, so first one, let me check. One from all over the world now, the dentist friend. Dr. Sarah, how about this? You speak the question and then Dr. Mustafa to help me answer.
Okay, first question is from University Anwar. She's asking, what factors do you take into consideration for choosing a rotary system or type of file for the different aberrant canal systems?
Actually, the factors depends on the metallurgy of the file. So most of the times now we are using the controlled memory files. And so simply, I'm going to say that if we are going to talk about the controlled memory files, it means it's the pre-bendable files. The file is already flexible, so you can do pre-bending of the file before working with it. This is simply the controlled memory file. Because if I'm going to discuss the metallurgy, this will take too much time. So in order to give you a proper answer, I believe that choosing the most effective rotary system is to have a proper system in your hands which you work perfectly with. So this is the most important factor. Sometimes there are good systems in the market, but you cannot use it very well. This happens with most of the clinicians. So you have to try, like if I'm going to say now the SucoPro rotary system, when I'm using the SucoPro rotary system, I use it in most of the cases, and I'm using the same sequence as I mentioned in my lecture. Sometimes I can shift to another system in a reciprocation mode if I need to challenge to tackle another challenge like an S-shaped canal, and I don't want to use a continuous rotation system. If I'm going to go for retreatment, sometimes I do retreatment using reciprocation. Sometimes I do retreatment using the continuous rotation. So it depends. But the most important thing is to choose the system which can work perfectly in your hands. And for the different canals anatomy, as I mentioned before, it's not about the system, it's about the sequence that you use. You don't skip files, you do irrigation between the files, you ensure patency of the canal, you go for the sequential steps I gave you, like glide path, and after that shaping, ensuring patency at the first of the canal. If you did this, most of the systems will work. But nowadays, we are shifting towards the controlled memory systems, which are the heat-treated nickel titanium, which can give you more flexibility and more respect for the canal anatomy, like the SocoPro rotary system.
Okay, next question.
Well, which file system for narrow canal?
You can use, I said in the lecture one thing. The beautiful thing about the SocoPro rotary system is that you can use it for regular canals because it has like 2506 or 3504. So you can use it for the regular canals, moderate curvature canals. And in the narrow canals, you can just decrease or minimize your apical preparation size up to 2504. So you have lots of systems in the world that you can use, which have the tip size of 2504. So for me, I can use the SocoPro rotary system. Sometimes I can go for the Wave 1 Gold. Sometimes I can shift for the 1 Resi from Micromega. So it depends. It depends. But most of the time, it's about the tip size and the taper. It's not about the system. It's about the tip size and the taper which are going to use in such a case.
Okay. So, and this one.
Okay. Another question: is there any way to find the MB2 without CBCT?
I have shared a while ago a slide which we can which included, sorry, 10 steps or 10 ways to find the MB2. You can find it without the comp MCT. Number 10 is the comp MCT. Okay, but you can use the ultrasonics, you can use the red line test, you can use the white line test, you can use the dentine map floor, you can use sodium hypochlorite bubbling action, you can use DG16, and all that after using the ultrasonics and removing the dentine shelf, which is already the part of dentine covering the floor in the pulpal floor. So you have to remove it and search for the MB2. So we have about 10 ways to search for the MB2 canal. But if you couldn't find it using any of these steps, always go for the comb MCT. It will make your life easier. Trust me.
Okay. Yeah, sure, we trust you.
Okay. Another question says most of the cases there are 3 canals in a molar. If only one canal infection involved, is it necessary to do 3 canals? If do only one, what will happen?
Of course, we should do root canal treatment for all the canals. We are not doing partial root canal treatment or partial pulpectomy. Never. We are going for the 3 root canals directly, because already this infected pulp, maybe it affected the coronal pulp. We have partial necrosis in the other canal, but which is not evident in the periapical area, so we don't know. So whenever we go for root canal treatment, we go for root canal treatment, complete root canal treatment. We don't do partial root canal treatment in one of the roots.
Okay, of course. Another question: which instrument system do you use in case of aberrant canals like C-shaped canal?
Okay, I want to mention here one thing. The C-shaped canals, it's not about the shaping, it's about the disinfection, especially in the C-shaped canals. Because in C-shaped canals, we are talking about the root canal spaces between the canals. You can have sometimes the straight canals in the C-shaped ones. I guess I will share my screen again for to show one thing. Just wait.
Please share your screen for me.
Yeah. Okay. Just wait.
If you share, tell me, I will add to the screen, then they can see your screen.
Okay, I will just share now. So now, this is a C-shaped lower left second molar. So when we
Wait a
talk
minute,
about the
I
C,
share. Okay.
this is the C-shaped lower left second molar. Okay. So if you got a look on this C-shaped lower molar, the canals are nearly straight here, and we have a slight or moderate or a small curvature in this mesobuccal canal. What we care about is the spaces between these canals, which was filled already by the bioceramic sealer and the gutta-perca. So it's about the disinfection in the C-shaped lower left second molar in the C-shaped canals, not about the shaping, because the shaping any system will do it. But the activation of irrigation and the disinfection protocol, it's the most important thing to do here. Actually, it's the cross section. If you took a cross section here or an axial cross section, you are going to see the C shape. So when we take a axial cross section and we look on top, it will look like a C, having 3 orifices connected with isthmi and root canal spaces, as you can see here, which was already filled. But the canals itself, they are nearly straight. So you can use any system. which works fine in your hands.
Okay.
Next question.
Another question: how many days dressing for calcium hydroxide in cases of weeping canal?
Usually, the calcium hydroxide, you can leave it as intracanal medication from 7 up to 10 days, not to increase 10 days, 7 to 10 days. And at the second visit, if you can get also weeping canals, you are going to repeat the procedure.
Okay. Do you recommend ninja access for maxillary removal with multiple canals in the middle third?
I don't recommend ninja access at all. Even in literature, we don't recommend the ninja access, because as I said in my webinar already, that the ultra conservative access cavity or the ninja access cavity, it doesn't add to the increasing of the fracture strength. Actually, the ninja access cavity can be of very high beneficial if you want to show off on Facebook, but on the literature, it will not help you to increase the fracture strength, but it will add more and more difficulties or iatrogenic errors during root canal preparation. You can go for traditional access cavity or conservative access cavity, and never ever ninja access cavity.
Okay.
Okay. Dentist Alex is asking, do I have to clean the isthmus in all lower molar cases, or only if find any hint of middle mesial canal presence, like oozing of blood?
We always clean the isthmus between the mesiobuccal canal and the mesiolingual canal in lower molars, because already this isthmus it harbors bacteria already, and we have to decrease the bacterial load present already in this part. So in order to decrease the bacteria, we are doing cleaning the isthmus using ultrasonics. So after cleaning the isthmus, okay, we are going to see if we have a middle mesial canal or not. So first, we do clean the isthmus to decrease the bacterial load, and then we search for the middle mesial canal. Yes, we have to.
Okay. So this question, Sam, wow, this lady many questions.
Okay, sorry. Okay.
Okay, so I guess Kali is asking, is it mandatory to complete my shaping up to 25 taper 6, or we can stop up to 25 or 2004 in the MB2 canal and middle mesial canals? Well, in the MB2 canal, I can stop my preparation up and the master apical file up to 25 taper 4%. 25 taper 4. In the middle mesial canal, either 2004 or 2504. But 2506 in middle mesial or MB2, never.
Okay. How to know which is our last file for preparation?
Okay. I mentioned the initial binding file. The initial binding file, it's the largest manual file that can reach the working length, okay? That the next file cannot reach the working length, which means if I have a file of size 20, it can reach the working length, manual file. I'm going to try number 25. If 25 didn't reach the working length, this means that number 20K file is my initial binding file. So you are going to increase 3 sizes up after that, and then you will end your preparation. And this is we do mainly now in the large canals. We don't do that now in the moderate sized canals. As I mentioned, we always end our preparation on 25 taper 6, 3004, 3504, it depends, because we mainly depend on the disinfection after that. So only in the large canals we use the initial binding file step.
Okay, the next question.
In what case will you do a CBCT instead of only IOPE?
I use the CBCT. I have to clarify one thing. I am a referral doctor, which means that most of the cases which are already referred to me are difficult cases. It's not an easy one. So most of the time,
you are professional.
Yeah, I'm a specialist. So at 90% of the cases, I have to take CBCT. because even sometimes someone is going to refer to me an upper canine, which you can see that it's an easy case. Maybe it's a very long tooth, but it's an easy case, wide canal. But actually, when I take a pre-apical X-ray, I can see it's a calcified, and when I take a CBCT, it's a totally calcified upper canine. So there is no an easy case for me to treat. That's why most of the cases which are already referred to me are difficult ones. That's why 90% of the cases I take CBCT. But if you are just a general practitioner or you are just doing root canal treatment on your daily practice, you can depend on the pre-apical X-ray. But in case you have a difficult case and you can feel that there is something weird or something bizarre during your root canal treatment procedure, you can always stop your procedure, put a temporary filling, send the case to have a cone beam CT, and then check it and then proceed for the second visit. Whenever you have difficulty, stop, take a cone beam CT.
Great advice. What is your shaping protocol for large oval canals?
It is the same protocol as I mentioned in my presentation. My file will be like 4004, 4006, 5004, 5006, depending on the initial binding file and the size of the canal. And mainly, I will tell you one sentence I had from one of my friends. He said one thing. He said that large canals are already prepared by nature for you. So what you only have to do is creation of apical stop and disinfection. So just use a large file to create an apical stop and start doing disinfection. Because whenever we do with our rotary files, we can never ever touch all the root canal walls, especially in the oval canals. Maximum walls to be touched are 65%. So what we can do about the rest of the 35%? Disinfection and irrigation.
Okay. Irrigation, very important.
Yes.
How do you obturate the aberrant canals?
It depends. As I mentioned before, now I'm shifting to bioceramic sealer and single cone technique. And even with the continuous wave of compaction technique, I'm using the bioceramic sealer also for the flowability of the sealer. So now for the aberrant canals, I'm using, if it's a double curvatures or severely curved, I'm using single cone with bioceramic sealer. If it's a C-shaped canal or having a very wide canal, I will going to use the continuous wave of compaction technique in order to ensure that all the irregularities are filled with getaperca.
Okay. Shamsuddin is asking you to repeat, if you please can you repeat the preparation of S-shaped canal sequence?
About this, maybe
I believe the
Facebook.
webinar, the webinar is already going to be saved on the COXO page. Yeah. So I believe you can check the sequence because the sequence is the whole presentation. So you can repeat, so you can check the whole presentation later.
You can see our COXO Facebook, then you can see this presentation again.
In calcified canals, how to achieve patency?
For the management of calcified canals, we have the ultrasonics, we have the C+ files, we have the trimmed manual K files. So we have the X-ray guided technique, we have the cone beam CBT. So we have lots of things to use for the management of calcified canals.
Still a little question more, so we try to finish.
Yes. What is mouse hole effect and what is clinical significance?
The mouse hole effect is when you don't do a proper traditional access cavity, and you have incomplete access cavity. So you are going to get like the mouse of Tom and Jerry cartoon. For the Jerry, the mouse, okay, Jerry the mouse, it has its home already. So if you don't do a proper access cavity or you did an incomplete access cavity, so you will not get a round orifice. Half of this will be just covered by the wall, like the mesial wall or the buccal wall in upper molars. So this wall, when it's covered the orifice, it will give you the mouse hole effect. And it will affect your shaping procedure because the files may break in the coronal part, and especially in the first 2 or 3 millimeters of the canal if you have already an incomplete access cavity. So you have to be sure of it.
Yeah. Wow, this is last class, our professor.
Yes,
Okay.
Dr. Rahman Khuli was is asking you from your experience, what is the incidence of MB2 in maxillary first and second molar?
It's not my experience, it's from the literature. The MB2 canal in the maxillary first molar, depending on the study, you can find that it ranges from 94% up to 98%. So we say that MB2 is always there. And this is, I'm talking about the maxillary first molar. So we say it's always there until proven otherwise. And how to prove otherwise? Take a cone beam CT. About the second molar, the percentage of the incidence of the MB2 canal is about 50%, and sometimes in some literature you can find it up to 55 or 58%.
Okay, another question from Shamsuddin. Do you recommend the use of continuous wave compaction obturation when we are using bioceramic sealer?
Yes, you can do that as long as the bioceramic sealer you are using is having a heat tolerance of 150 degrees. You can use already the sealer is present in the market when you are using the down pack pen on 150 degree. But now we are having more and more bioceramic sealers which are heat tolerant present in the market. We can use it up to 150 or sometimes 160 degrees. So like different brands present in the market.
And for the last question, I think this one, how to deal with very narrow canal, we have already answered. Our last question, how important is the access preparation? What factors play a role in the proper access preparation?
I think already answered this one.
Yeah, I answered it already.
Yeah. So this is the last one.
Yes. How about calcium hydroxide inside canal for 3 weeks?
No, 1 week up to 10 days.
Up to 10 days.
Yes.
That's
Okay.
that's all the questions. Thank you so much for your patience, Dr. Mostafa, and for answering all our questions.
It's my
Yeah,
pleasure,
thank you
Dr. Sarah.
for
It's my pleasure,
Dr.
Julie.
Mustafa. So many questions you answer. Okay, so now is the last part. Everyone waiting for the lottery. So
Yes.
let me turn to share my screen to see this time what lottery we use. Okay,
Any
this
any
time
chance any chance I can win, Julie?
you can comment here. They will have your name. Okay, you can see this. This is our nano. Dr. Sarah, you can introduce her about that.
Yes, the ZB686 Nano Light Pure, the new one from COXO, it's really very nice. It's metallic and small and light. It's very intense. Also, it has two functions. It has a curing function and a carrier detection function, and it's also supplied with an extra battery, and also it has a radiometer in the stand. So it's really very nice and very elegant, very nice design, and also very handy.
Yeah, really, this is after COXO make out this model so popular. So now let's begin for the lottery. Let me check how many dentists common this time. I think they didn't get this type post. Wait a minute, let me check again. Need to fresh again. So wait a minute, I really need to get this cross dentist common Then we can choose this course. Okay, we renew the new one. And then let me check how many dentists this time get the comment. More than now this time we will save some, collect some of repeat one. So now it's about 32. Then Dr. Mustafa, so waiting for you.
So now I have to say stop or what?
You just say 1, 2, 3, begin, then they will automatic.
Okay. 1, 2, 3, and go. Let's go.
Let's see who is the winner. Wow.
So Khulud Sharqawi.
From Egypt.
Yes.
Well, you see, this course is so many from different countries, and then so lucky that you are from Egypt. We get the winner is from Egypt. Okay, so congratulations for this dentist.
Congratulations, Khulud, for winning the light cure. I believe you are going to enjoy it so much. And Khulud, if you can give it to me to try, it will be a very good idea.
Okay, Dr. Silva, you can connect. Okay, let me see for our next course. Every week, COXO have the course. Next time is 15th July next week.
15th of July.
Yeah, so I need Dr. Mustafa to help me introduce our next course.
For sure. The next course will be on 15th of July. It will be with Alberto Dagna from Italy. He's one of my best friends, and he's a very dear colleague, and he's one of the most eminent clinicians worldwide. He's an adjunct professor in the University of Endodontics in the University of Padua in Italy. He's a very well-known international lecturer, and his topic will be about the irrigation and 3D cleaning in the modern endodontics. I believe you are going to enjoy it so much, and you are going to learn so much from him due to his great knowledge and his great clinical tips and tricks.
Yeah, this is very famous.
Yeah, the webinar will be on 15th of next week, right?
Yeah, next week.
Very good.
Okay, so that is our course. So now it's time to say goodbye for everyone. Wait a minute, I will move my screen. So come to say, where is Dr. Sarah?
I don't know where is Sarah.
maybe she's scared about to surprise the nano. I think we can surprise, sure. Yeah. Okay. So maybe the internet not good for Dr. Sarah. I see the internet maybe not so good, and then come late. So let me to add Dr. Sarah come again.
Yes, I am sorry we had the internet problem.
No problem.
Yeah. Okay, so thank you everyone for this time. It's time for finish this course. Thank you, Dr. Sarah. Thank you, Dr. Mustafa. Special for Dr. Mustafa for take so long time for so good presentation.
Thank you so much, Julie. Thank you, Dr. Sarah. I was really happy to be with you today. Thank you so much.
Yeah, you're welcome. So say goodbye to everyone. We see you next time. Hope to see you in Egypt.
Yes, we
Goodbye.
For sure, soon. Bye-bye, everyone.
Yeah.
Bye-bye.
Bye-bye.
Bye.